I'd like to introduce Dr. Clara Yang. Dr. Yang is a professor of urology at the University of Washington. She's been on faculty at the University of Washington since 1993 and currently is urology section chief at Harborview Medical Center and staff physician at the VA Puget Sound Healthcare System. Her clinical practice is in benign urological conditions. She has received federal research funding continuously since 2006, focusing on lower urinary tract disorders and ultrasonic treatment of kidney stones. So I think you can see that she has tremendous expertise to share with us today on urological symptoms in the older adult. Welcome, Dr. Yang.
Thank you, Dr. Cochran. Can you hear me?
Absolutely.
All righty. So, my talk today, I'll just say, isn't going to be focused on urologic diseases or conditions, but more a focus on how to approach the older adult with urological symptoms to the primary care community. And as I understand, this audience has a wide range of expertise and training. And so some of this might seem a little basic, but I just want everybody to be sort of on the same page. And I think much of this might be good review for those of you who are seeing people with urologic symptoms. So after a little introduction, I will review some of the anatomy and function of the lower urinary tract, which is what we're going to focus on today, and common symptoms related to urination in the older adult. So what is urology? After 35 years in this business, my practice is a referral practice, and I see referrals and questions posed by my referring colleagues, and there's a wide range of understanding of what urology is, and so I'll start with that. And and it is diseases and disorders of the genitourinary or urogenital tract, depending on how you want to say it. Um, and that means to us urologists, urinary tract function. This is not related to kidney function. The function of the kidney is to filter, waste products out of the blood, and urinary tract function is the passage of urine through the body and out of it. So disorders and diseases of the bladder and prostate relating to the storage and evacuation of urine. Kidney stones is also part of urology, and you might say, well, kidney stones is a kidney problem, but kidney stones, and it is, but kidney stones block the passage of urine, and so becomes a urological problem. Genital and sexual function, because the organs related to genital and sexual function are intimately related to the urinary tract, and urologists deal with primarily male genitourinary dysfunction in the manner of erectile dysfunction and surgical treatment of erectile dysfunction and male infertility. Genitourinary infections, we don't typically manage the medical side of infections, but we do manage the surgical side of infections and genitourinary organ malignancies. We also don't manage the, medical oncology side. We manage the surgical side. And as a summary, urology affects men and women. So we treat males and females, and we treat children and adults. So the lower urinary tract symptoms and are myriad, and here we're going to be focusing on three of them: nocturia, daytime frequency, and incontinence. Um, and these are symptoms, whereas urologic conditions or diseases can include urinary tract infections, BPH, or genitourinary syndrome of menopause. Um, I'm not going to go into the conditions during this talk, although maybe during the question session we can field some um, discussion on that, but mostly focusing on some of the symptoms, just to see what bring out some of the pertinent factors in approaching the older adult with urinary symptoms. So to start, a little anatomy and function review. So the urogenital tract is any part of the body that comes into contact with urine. So the urinary tract is broken down into the upper urinary tract, which is the kidney and the ureter, and the lower urinary tract includes the bladder, and in men, the prostate, and the urethra, the passageway of urine out of the bladder to the outside world. As far as genitals are concerned, in the male, there's the penis and the testicles and the associated tubing, if you will, associated with the testicles for the passage of sperm. And in the female, the genitals include the clitoris and the vagina and the tissues surrounding the opening of the vagina. So men and women basically have the same lower urinary tract setup, and that of the bladder and the sphincters, the muscles which hold the urine in the bladder. So the ureters drain the urine coming from the kidneys into the bladder. The bladder is a it's a ovoid muscle, and the detailed anatomy is not necessary to know, but the muscle is then lined with a layer of cells that keeps the waste products in the urine from being reabsorbed. So the bladder functions as a reservoir or a holding tank. And there are two muscles which hold the urine in. One is called the bladder neck or internal sphincter, and then there's an external sphincter, which is part of the pelvic floor muscles. And the bladder neck sphincter is the primary muscle that maintains continence or holds urine in the bladder. And the external sphincter, which is part of the pelvic floor, is a secondary muscle which holds the urine in, particularly in situations where there's increases of intra-abdominal pressure, which tries to push urine out of the bladder. In men, there's a prostate that grows around the urethra, and in women there is not. And in men, there's a longer passageway down the urethra to get out the tip of the penis. And in women, the entire length of the urethra is probably, 4 to 5 centimeters. In women, this is another view. This is a more detailed anatomic view showing the urethra and the bladder. And this bracket here outlines the internal sphincter or the bladder neck. And then on the right side of the screen shows the bladder and the urethra in the context of a side view. So you could see how it relates to the vagina and the uterus and the rectum and the anus. Barb, is my cursor visible on
Yes,
the?
it is.
Okay, great. I was just wondering if I was doing that without anybody seeing it. Okay. To compare, in the male, again, here's the coronal view. In the sagittal or sideways view, the rectum and anus is here, and the bladder is just in front of it, anterior to it, right behind the pubic bone, just like it is in women. There's the prostate gland right here, and here's the pelvic floor where the external sphincter sits and the internal sphincter is up here. Um, and for those of you who have who take care of older men and are concerned about prostates, this is how we examine the prostate through the rectum. We can palpate the prostate through this very thin tissue wall, and so it's the only place where we can do an exam of the prostate. So the function of the lower urinary tract can be broken down into two um, two phases. One is a storage phase, and one is an evacuation phase. And so the bladder functions to store urine until the bladder is full, and then until it's socially appropriate to evacuate. So it's a reservoir, and during this filling phase, you can compare it to the heart um, function, which is diastole, and important for healthy urinary tract function is to store urine at low pressures, and that's called compliance. And as I tell my trainees, it's the phase where the bladder is supposed to be stretchy, so that it can fill and hold volumes of urine at low pressure. The other phase, or other stage of the cycle, is evacuation, and that's um, the the function of the bladder is to evacuate urine efficiently, and this is the systole phase if you're comparing it to heart function. And also, healthy function is low pressure contraction of the bladder for evacuating urine. And at the bottom of the slide is a cartoon of the filling phase. And then once the bladder is full and it's socially appropriate to do so, the internal and external sphincters open, and then the bladder contracts so that it squeezes all the urine out in one fell swoop, and then the sphincters close and the cycle starts all over again. And that's sort of the um, breakdown, if you will, of healthy lower urinary tract function. This is another summary of what I just said. The fancy term for this is micturition cycle. Micturition meaning voiding. You can call it the urinary cycle, but just recognizing that there is a storage and there is an evacuation phase. And the vast majority of time, we're in the storage phase. We're voiding only a few times a day, some of us more than others. But the vast majority of our time is spent in storage. And so many of the urinary complaints that people come in with are related to difficulties in storage, as well as difficulty in evacuation. Now, this is an example of a species that doesn't have a micturition cycle, and probably they don't have any urinary symptoms. Birds do form urine, and here is the little kidney in this bird. and it has a ureter, and it dumps into this passageway called the cloaca. And the cloaca in birds also receives the solid waste products. And the cloaca doesn't have any sphincter muscles, so there's no storage. It just, as the waste products, solid and liquid, are formed, they just pass out of the system without control. So now let's look at the evaluation of the older adult with lower urinary tract symptoms. Symptoms increase in incidence with advancing age. And I say, if you live long enough, you will see a urologist. Not all people who are older get symptoms, but if you live long enough, you will have noticeable changes in your lower urinary tract function. The changes to the tissues, the changes to the organs of the lower urinary tract are irreversible, as are many organ tissues with the passage of time. But that being said, the symptoms resulting from those tissue changes can be managed, and the symptoms can be mitigated in many instances, not all the time, but in many situations. And another factor is that urinary changes with aging are not preventable because those changes happen with time. They're all mostly related, if they're not iatrogenic, like as a result of surgery or something, or is that one thing to keep in mind is that the preservation of urinary function is primarily related to overall health. So if your cardiac, pulmonary, neurologic organs are all working well, it is highly likely your urinary symptoms, urinary organs and tissues will be functioning well. Conversely, if you have significant cardiac dysfunction, if you have significant neurologic dysfunction, you are not going to have healthy urinary function also. And I bring that up because I get lots of referrals for people with urinary symptoms. And, the question from the patients is, how come I have these symptoms? And I try to explain that, we can't expect your urinary system to be working well when many of the other organ functions that are not healthy. Another thing to keep in mind is that lower urinary tract symptoms are not pathognomonic of a particular condition. And many urologic conditions, many different kinds of urologic conditions, share similar symptoms. So urinary frequency, for example, is a manifestation of a number of different urologic diseases or conditions. And so you can't say, oh, this person is presenting with this urinary symptom, they must have this. That's not necessarily true. And so just keep that in mind as you're generating differential diagnoses for people that you're seeing, or you're taking care of people with symptoms. It isn't necessarily related to what you think it might be related to. if you don't have a clear diagnosis. And then finally, not all dysfunction or urinary symptoms are bothersome to the patient or need treatment or management. Many urinary symptoms are occur, but if they're not necessarily a manifestation of a unhealthy situation, or that symptoms themselves aren't unhealthy, if you will, and taking into account patients' degree of bother should be part of the treatment plan if there is going to be treatment offered. Now here's a loaded slide where I could give an hour-long talk just on this slide, but factors affecting lower urinary tract function and thus symptoms in older adults. The first being general health. As I mentioned earlier, if there are multiple things not going well or not, if the person overall is not healthy, it's highly unlikely that their urinary function is going to be healthy or working well. And I'd like to call out neurologic health because this is one organ system that's highly integrated. The nervous system is highly integrated into lower urinary tract function. And if there is neurologic disease or injury, particularly central nervous system disorders, which occur more commonly in older adults, there is going to be a negative impact on urinary tract, urinary function. And even peripheral neurologic disease, severe and even not so severe peripheral neuropathy, say from diabetes, definitely negatively impacts neuropathy, definitely impacts urinary tract function and symptoms. One of the 4 M's, mobility. Mobility definitely impacts urinary function in that even if you can even if you have good sensation of when you need to evacuate urine, if you can't get to the toilet or you can't independently toilet yourself, then that's going to affect your lower urinary tract function and contribute to symptoms and contribute to, distress, if you will, from your urinary tract. Medications. Here is a very underestimated factor. Of the thousands of medications that exist in our pharmacopoeia today, most medications that impact the urinary, with some impact on the urinary tract, and many, many do, even though they're not indicated for urinary function, most medications with an impact on the urinary tract will act to make urinary function worse. So this is any medication that affects the nervous system, and opiates, medications for irritable bowel, medications for depression. All of these can affect the urinary tract and make its function less efficient. In the older adult, we're dealing constantly with the sequelae of polypharmacy. And so even though the side effect profile listed on a particular medication doesn't include urinary retention or urinary symptoms on it as a side effect, once you add this particular medication who into somebody's regimen that already has a lot of other medications, particularly centrally acting medications, then side effects can be, you know, accentuated. How's that? And then finally, in the older adult, drug metabolism is definitely different than in the younger patient, which compounds effects and side effects of medications on the urinary tract. And I mentioned this earlier, benign infectious conditions and symptoms are often not cured, just managed. So in approaching the patient with urinary complaints in primary care, as with any patient in any healthcare encounter, start with the history, the typical how, when, what makes it worse, what makes it better for any symptom. And then a physical examination. And I encourage all my primary care colleagues to not skip a physical exam. Okay. And the reason for that is because even though the vast majority of people have quote unquote normal anatomy, there can be changes to the genitals that might explain symptoms, or you might see the consequence of symptoms. Say, an older person coming in with the complaints of incontinence, and you ask, well, how bad is it? And they say, well, not that bad. I just started noticing it. And then you examine them and they've got this raging diaper rash, if you will. Just, I'm not advocating that everybody get a rectal exam if they're a male or a pelvic exam if they're a female, but just a quick look, just to see if there's anything obvious to explain their urinary symptoms. And and mostly just to keep in mind what a normal exam might look like, and made so that when an abnormal exam comes up, you can recognize it. A lot of people don't recognize some of the changes that happen with aging to the external genitalia of men and women, and might find, if they do an exam, find something they don't recognize when it's actually a normal change with age. And conversely, if you are well acquainted with the physical examination of an older adult, you can recognize something that does not seem typical. And then in the primary care clinic, an ancillary evaluation for anybody with urinary symptoms may include a urinalysis and urine culture. And one thing to keep in mind is that some older adults, due to mobility issues or due to anatomy, cannot give what we would call a good specimen. And what we're looking for ideally is what we would call a midstream urine specimen. So some women who are not very dexterous might not be able to separate their labia with their hand while holding the cup in place. And especially if their body habitus is large. And what happens is that a lot of contaminants from the vagina or the perineum get put into the specimen, and then they get diagnosed with, quote, urinary tract infection, when it really isn't a urinary tract infection. It's a urine specimen with contaminants from not being able to give a midstream urine. Older men who are uncircumcised might have some inflammation of their foreskin and might not be able to pull back their foreskin, and thus the urine that comes out and gets into the cup is a lot of skin bacteria and skin inflammation that shows up in the urine specimen. Also, men who are of large body habituses, some of them can't, if they're very big, they have what we call a buried penis. Their penis hasn't shrunk back so much as the adipose tissue of their surrounding their penis sort of drapes forward over the penis, and they can't grab the head of their penis to actually direct the urinary stream. So these are some of the factors that might come into play when trying to interpret the urinalysis and urine culture. Here is a pretty long list of urinary symptoms. And as you can see, there's a wide range of things. This is what people are distressed about or come in and have questions about. And these are, as I mentioned up top, they become more common with age. Now, we can't address all of them, so today we're going to talk primarily about urinary frequency, incontinence, and nocturia, because these are symptoms that are common to men and women. Sorry. So let's start with nocturia. And I'm going to start with nocturia because this is, to me, the most morbid symptom of for older adults. Nocturia is waking during the night at least once to urinate, and it becomes clinically significant, or maybe we've just arbitrarily designated clinically significant if it's more than two times or more. And it's the most common reason for interrupted sleep in the adult population, or stated as the most common reason for interrupted sleep in the adult population. What is the impact of nocturia? Excessive daytime sleepiness, cognitive dysfunction as a result of that. It is certainly a huge negative impact on quality of life. And this is the point that I want to emphasize. There is actually a mortality risk associated with nocturia due to falls. It's estimated that of people who get up at night to urinate, if they fall, one study quoted a 10% mortality rate, because when you fall in the bathroom in the middle of the night, you're not functioning at your best. You're not awake. If you're unstable to begin with, and the ceramic bathtub, the ceramic sink, the hard floor, all of that results in head injuries, broken bones, and in the older adult, those things can spiral and ultimately result in death. So this is all my older patients who come to me with nocturia, especially if they're men. I try to give them hints for or suggestions for behavioral modifications to mitigate the nocturia. It is very prevalent. The majority of older patients get up at least once a night. One study quotes between the ages of 50 and 60 years, about 50% of people are getting up at least one time a night. And by the early 60s, about 25% are getting up two or more times a night. I personally think that these numbers from this particular study are a little high, but clearly there is an increasing incidence of or prevalence as people get older. Now, one of the reasons or one of the explanations for getting up to void at night is that people are making more urine at night, which then causes them to get up. Caffeinated beverages and alcoholic beverages in the couple hours before sleep can contribute to that. And those groups of beverages are diuretics, so they can encourage urine production. Excessive fluid intake prior to and during sleep time. I've never been one to do this, but a number of people will have a pretty significant snack before bed, which includes beverages or like a big piece of fruit, with a lot of fluid in it, and wake up at night with say a dry mouth, and they'll drink a glass of water. And so that all contributes to more nocturia. Older adults also experience antidiuretic hormone rhythm derangements. And so antidiuretic shuts down the urine production or slows urine production, but this hormone, the release of this hormone at night can be altered in the older adult, and so more urine is produced. Obstructive sleep apnea, OSA, leads to hypoxia, which then leads to a hormone called atrial natriuretic protein secretion, and that's also a diuretic hormone, which then mobilizes more urine production. And then finally, in many older adults, they have peripheral edema. And when you have a lot of peripheral edema, if you're sitting in a wheelchair all day, or if you've got heart failure, and then you lie down at night, the edema mobilizes and then goes into circulation and results in urine production. Other causes of nocturia, the older adult that is not related to increased urine production, the older adult has a different, there are changes to the sleep cycles in older adults, and sleep is definitely lighter. And so there are more awakenings. And many people report that if you drill down to it, they say, well, I woke up because I felt like I had to pee. But if you really query them, you find out they're just awake. And then they said, well, since I'm awake, I might as well go pee. And so that's a reason for nocturia, but it isn't directly related to increased urine production. And then also with obstructive sleep apnea, we find that people definitely sleep better. And I think this is related to sleep cycle, changes in the sleep cycle, or to be more deep. And so they don't wake up as frequently, even with the same amount of urine production. So take home from this is this nocturia is a source of morbidity and mortality in the older adult. One factor to keep in mind is not all nocturia is due to BPH or overactive bladder. And in the primary care clinic, behavioral modifications first, and there's a diagnostic tool called avoiding diary. You can ask people to write down what they're drinking, in the evening, and give them a urinal and ask them to measure how much they're peeing over the course of the night. And so maybe you can help them with behavioral modifications to try to cut down urine production and things like that. Daytime urinary frequency. This is sort of I should say nocturia is a variation of urinary frequency, and daytime frequency is voiding more frequently than perceived to be normal. It's not as morbid than nocturia, but it is very bothersome, and it can be related to some negative impacts. So the first question is, what is normal urinary frequency and what is healthy urinary frequency? The sensation to void is healthy, and the act of voiding is healthy. But the sensation to void is like a noxious sensation. We humans attend to that sensation, and even though it is healthy to have that sensation, it becomes an irritation and an inconvenience if it happens too frequently. Now, frequency can be associated with unhealthy conditions such as cystitis or urinary tract infections. It can be associated with neurologic impairment, or it can be due to benign causes such as changes in your diet and changes in your urinary sensory threshold, as happens with age. There is a very long list of things associated with urinary frequency, many conditions. And as I was just saying, the threshold for feeling the need to void is at a lower volume in older adults. And that can be due to neuropathy, loss of detrusor compliance or bladder compliance. In the older adult, the impact of bladder irritants. There are certain beverages and foods such as alcohol, caffeine, carbonation, citrus juices. Those are known as bladder irritants, and the impact of those beverages is greater in the older adult than in the younger adult. In the older adult, urinary frequency can be prompted by emotions, the fear of leaking urine, the fear of being away from a toilet for long periods of time prompts people to go to the bathroom even when they don't feel like they need to void. They just want to empty their bladder so that they don't have to attend to it if the circumstances are such that they won't have access to a toilet. So that generates urinary frequency. And then in men, as they get older, that frequently is associated with urinary frequency. And the impact of frequency can limit activity. And if mobility is limited, the frequent desire to void increases the risk of incontinence and creates more of a care burden. I didn't put this on the slide as I was talking. I just realized what is normal. There is no normal. It's um, based on how much you're consuming. Um, but let's say the median range of voiding episodes during your waking hours in most adults is between 3 and 8 times during your waking hours. But that's sort of uh, yeah, that's just a statistical range. Certainly, if I had a 2 liter bottle of Diet Coke, you know, I would be peeing probably 20 times during my waking hours. And that would be sort of an appropriate response to that. So it's not in and of itself unhealthy. Um, and so I hesitate to define normal, or I rather just put out there the median range. So the playwright Henry Miller is given there's this quote here: to relieve a bladder, full bladder, is one of the great human joys. And I'll say, except if it's more frequent than you think it should be. So when a patient comes to you in clinic with saying, I pee too often, I would say the first thing to do is align the definition for frequency or too often. And as I mentioned earlier, 3 to 8 times in a waking, the waking hours is the normal range. Now, younger adults definitely don't, as a group, don't void as frequently. And so many people get older, and if they voided 3 to 4 times in their waking hours, as they start voiding 6 to 7 times in their waking hours, feel like something must be wrong, but it's not necessarily so. Assess the volume and type of fluid intake and query other accompanying symptoms, to generate your differential diagnosis of what could be causing this, if it's other than behavioral behavioral reasons, dietary reasons, or otherwise benign reasons. Now, the last symptom I'm going to talk about is incontinence, which we define as the involuntary loss of urine. There is a spectrum of severity for involuntary loss of urine, from a few drops when you cough to total inability to hold urine, such that you don't even use the toilet because your bladder never fills up. Urinary continence, control of our urine, is a deeply seated desire, okay? And it's emotionally charged, because when we lose that or feel like we're losing control, that generates a lot of distress in some people. And the distress is not necessarily related to volume lost. Okay, some people are very distressed with loss of a few drops of urine. Some people who are pretty darn incontinent, and you can tell from across the room that they're incontinent, aren't distressed. So the distress is wide-ranging, and it is also not related to the actual amount of urine lost. Incontinence is associated with aging, because with the passage of time comes more neurologic disease, comes surgery, pelvic surgery that might result in continence or incontinence. And then anybody who's been pregnant, not just those who've had vaginal deliveries, but anybody who's been pregnant has um, loss of urinary sphincter integrity that doesn't necessarily show up um, during the reproductive years, but with the passage of time, with the forces of gravity, if you will, at work, results in incontinence. And it is a huge, huge burden, not only financial, but also caregiving, emotional burden, and quality of life burden. A couple myths about incontinence. One is urinary tract incontinence does not increase urinary tract infection risk. Okay, it does can result in diaper rash or skin breakdown, but one's urinary tract infection risk is not increased with involuntary loss of urine. And then incontinence in and of itself is not inherently unhealthy. It's unhygienic, but it is not inherently unhealthy because we're supposed to evacuate our waste products. So keep that in mind when approaching the patient with incontinence. Now, there are a number of types of incontinence, and I'll run through these briefly just to keep in mind here that there are many causes of incontinence. So when somebody complains of loss of control of their urine, it isn't going to be all due to the same thing in every person. So stress incontinence is loss of urine during increases in intra-abdominal pressure, and that's like with movement or coughing or sneezing. And there's the pathology for that lies in low outlet resistance, particularly that internal sphincter. And this can happen this is the kind of incontinence that happens in women, and it's a side effect of pregnancy, and particularly vaginal delivery. Men can get this kind of incontinence too if they have prostate surgery because their internal sphincter is damaged. And so here with the prostate, with the TURP operation, the rotor-rooter, if you will, the internal sphincter is carved out as part of the, opening the passageway for the urine, and the internal sphincter here, the nerves to the internal sphincter are injured during pregnancy and childbirth, and the neurologic reserve, if you will, then starts to come into play when with the passage of time. There's also urgency incontinence. This is loss of urine due to a sudden onset of a sensation to urinate that you can't put off. Okay, so typically we would not have these sudden onsets of a sensation to void. If we have a sensation to void, say that when we're standing in line at the grocery store, we should be able to say, okay, I don't really want to go to the bathroom right now, and let's wait till we go home, and the brain sends signals down to the bladder to not squeeze. But due to a number of conditions, especially neurologic conditions, that ability to tell your bladder to not squeeze diminishes. And this is, in physiologic terms, a loss of the inhibition of the micturition reflex. It can also happen with low outlet resistance as well, sphincter damage. Mixed incontinence, very common in women to have stress and urgency incontinence occurring together. There's overflow incontinence where the pressure in the bladder is high because it's overfull, and then the urine starts to leak out. It overcomes the outlet resistance. And nocturnal enuresis, incontinence while sleeping, and in otherwise continent adults, this occurs with sedatives, sleeping medications, or alcohol use that puts people to sleep so deeply that they do not wake with the urge to void. Finally, the last kind of incontinence I want to mention is post-void dribbling, and this is very common in men, and it's not typically considered incontinence because it's the pathophysiology is urine that is lost after it passes out of the bladder and after it passes the sphincter. So in this sagittal view, men have this portion of the urethra, which is actually a little bigger than is designated here, but it can hold about a tablespoon of urine. And as men get older, the muscles to squeeze that out, that last tablespoon out, gets weaker. And so then after voiding, after you pull up your underwear, then the tablespoon of urine that's here just starts to dribble out. So it's not a phenomenon of a weak sphincter or a bladder squeezing when it's not to. It's urine that's left behind in the urethra that doesn't get squeezed out. But men, call that incontinence, and it is very distressing. So to finish up, urological symptoms in the older adult, common in the primary care practice, more common with advancing age. Symptoms are not associated with a particular disease or condition. We didn't talk about any of the conditions, urinary tract infections, BPH, overactive bladder. Symptoms can cross over the different conditions, but many urological symptoms can be managed with behavioral modifications. All right. So that's the end of my presentation. Dr. Cochran, how should we proceed?
Sorry, just got a phone call as I was trying to switch over. Thank you so much, Dr. Yang. That was really outstanding and very relevant for the encounters that we would have with older adults. It looks like I have a couple of questions. Wondering if you could share some pearls on recognition, management, and prevention of delirium associated with UTIs in older adults. Is there any evidence for use of NSAIDs or anything else to reduce pro-inflammatory interleukin release purportedly associated with delirium?
So, I don't think so. You know, UTIs causing delirium in the older adult is a very difficult situation, and in many people, it's related to poor or inefficient emptying of the bladder. Okay. And there is no surgery or medication to make the bladder squeeze more efficiently. And I know that doesn't address the, pro-inflammatory release of cytokines, whatever other proteins, but yeah, the short answer is I don't know of anything to address the particular thing you're talking about, and there is no easy answer to preventing urinary tract infections in the older adult. It depends on a lot of different factors.
Thank you. So Lisa is wondering, can a pessary cause urination difficulties?
Um, a pessary could, um, yes. And let me back up to a slide at the beginning. So, and this slide right here, in the sagittal view of the female, the pessary is a plastic object that's placed into the upper vagina, and it is used to mechanically hold up the uterus or the bladder to keep it from prolapsing into the vagina. Um, it can also be used to treat incontinence, stress incontinence, because the placement of the pessary here pushes forward the internal sphincter and it pushes it anteriorly, and there's a bone here. And so it provides a little more outlet resistance so that when you cough or sneeze, you have a little more resistance here, and you wouldn't be as likely to leak. But conversely, it could press hard enough such that the bladder, if it's weak, can't squeeze out past the resistance. So in theory, yes. In practice, I don't think it's that common because for women with prolapse, which for which the pessary is being placed, their pelvic floor, their internal sphincter is probably not functioning well. And so that pessary actually helps, but probably in a minority of instances could cause some urinary difficulties.
Thank you. David is wondering, would you please say something about non-prescription supplements or other methods to alleviate the symptoms of BPH and associated nocturia?
So, um, BPH is the benign prostatic hyperplasia, and it starts occurring in men after the age of about 55 or 60, and it causes urinary symptoms. Um, and in classic teaching, any urinary symptom in men is due to the enlarged prostate. But we know that not to be true now. Um, but there's still that idea that an enlarged prostate is the root of all voiding symptoms in men. Um, there are supplements which are offered to men for the treatment of urinary symptoms, and the more effective ones are hormones, mild hormones, which affect the prostate size and may relieve urinary symptoms. Um, I do not advocate for them myself. I don't prescribe them myself, but I tell men who do take them and feel like they get effect, it's not a problem that I know of to continue them. And just make sure you're not paying too much money for that. Okay. There is no supplement that I know of that specifically treats nocturia. Um, so it would be nocturia in the context of voiding symptoms attributed to prostate enlargement.
Okay. And Ivan is wondering what causes burning when urinating in females besides UTIs.
The most common reason, including, all the reasons, including UTI, is uh, genital tissue atrophy. Okay, so with the genital tissues and including the urethra in women are very hormonally sensitive. Estrogens um, bring more integrity to the tissues of the urethra as well as the tissues of the vagina, or introitus, I should say. And with removal of those, or yeah, with removal of those female estrogenic hormones, the tissues lose their integrity and become more irritated more easily. Um, if and there are a lot of women who are aggressive wipers, if you will, and get and abrade their urethra, and that can result in dysuria, pain with urination, and just generally speaking, get dysuria. So one of the if you've ruled out infection in a postmenopausal woman, um, local estrogen replacement in the form of estrogen creams or estrogen supplements, such as the S-string, or maybe even the Nuva ring, that can bring local estrogen to those tissues and relieve dysuria.
Thank you. Could you comment about the benefit versus risks of medications available to treat incontinence in older adults, antimuscarinics, and I'm not going to pronounce this right probably, but mirabegron? Mirabegron?
Yes. Okay, hold on a second. Um, Anticholinergic medications are the first line medications for what we call overactive bladder, which is a term used to describe anybody with the syndrome of urgency, frequency, nocturia, with or without incontinence. And there are a lot of different causes to that syndrome. And so anticholinergics, however, are one of the mainstays because that's one of the few pathophysiologies we understand that create this urinary symptom syndrome. Anticholinergics are what they do is they slow the bladder down. So when you get a sudden urge to pee, you buy more time to get to the bathroom, basically, so that you're not incontinent. But as I was mentioning earlier, there are multiple different pathologies to explain incontinence. And so in the older adult, I would not jump to that and use anticholinergics, because we know that anticholinergics have terrible side effect profile for the older adult. They cause cognitive dysfunction, they cause constipation, and I didn't bring this up, but constipation is highly associated with urinary symptoms. Okay, and so I discourage their use in older adults. And when I say older, generally speaking, 70 and older. But if you're 65 and already have evidence of microvascular diseases manifesting as, a little cognitive dysfunction, I'm not gonna give those medications if I feel like they have urgency incontinence. It does not treat stress incontinence. It does not treat post-void dribbling. It does not treat overflow incontinence. In fact, it makes overflow incontinence worse. So you have to really drill down and see if they have urgency incontinence before you prescribe that medication. And even if they have that symptom in the older adult, I don't prescribe it. The people, older adults with strokes, Parkinson's, um, they all have urgency incontinence for which this medication is perfectly suited. However, they also have cognitive dysfunction as well. So that's another contraindication for me to give anticholinergics. Mirabegron, the beta agonists, that's got less of a side effect profile, except that it can exacerbate hypertension. And hypertension is a very common phenomenon. And it isn't very well covered by insurance. Okay. So, if you don't submit the pre-authorization, or if the pre-authorization isn't whatchamacallit, approved, your patient can't get that medication. And it is very expensive if it's not covered by insurance. And it's very expensive even if it is. And if the older patient does want to go on this medication and has known hypertension, I'll titrate it very slowly and make sure that there is going to be an effect, okay, as well as side effect. We're monitoring effect. It's hard to monitor effect with a slow titration of medication.
Really helpful information. I had not been aware of that medication, so thank you.
Mhm.
I'm posing a question. I don't have other questions coming in at this point, but I'm posing a question to attendees to ask for a little bit of interprofessional insights, I guess, in your encounters with older adults. How, if at all, do you become aware of urological issues? How do you sort of ask about that? And do you get asked to advise on management strategies, and how do you manage that? And feel free to let us know your setting or discipline. I guess while I'm uh, waiting, I'm wondering to what extent you have the experience, Dr. Yang, of something that I hear a lot of, which is that older adults sort of assume, and sometimes family members as well assume that, for example, incontinence is just to be expected, and so they're not sort of raising the question with their providers.
Mhm.
Maybe then you don't see them
Yeah,
because it doesn't come to you, but
yeah.
thoughts about that, and how we might um, probe or pose that possibility to inquire of an older person, uh, if maybe they actually are having issues, but they just figure it's an aging thing, and so they don't bring it up, even though it could be managed.
Yeah, I mean, I would say as the primary care provider, you probably have a checklist of, you know, sort of organ survey.
Mm-hmm.
Um, are you are you safe in your home? Are you falling? And, just are you dizzy? Just how's your how do you feel your urinate, you know, ask them about their urinary habits. Do they have any concerns about their urination? Same with sexual function, just ask. Do you
Mm-hmm.
have any concerns about your sexual function? Genitourinary function definitely is low on the list for people to query. And I get it because there are so many other things for the primary care provider to attend to, Um, and so I would just say, just like with the physical exam, desensitize yourself and normalize it and make it part of your just make it part of your routine. Um, a lot of people are are not skittish, but don't want to, you know, impose on other people or I don't know, make them uncomfortable by asking them about private issues like urinary habits, sexual habits. But if you are, if you want to be comprehensive about it and bring up, you know, Dr. Cochran's point about how do we ask about it, just just ask about it, just general as you would anything else. Are you dizzy? Are you able to, walk as you would like to? Are you able to, you know, urinate as you would like to? Is your sexual function, you know, of concern to you?
Oh, that's helpful. Loretta says she does home visits for many seniors for therapy. Many complain of urinary issues. I use mindfulness, breathing strategies to calm the stressful anxiety thoughts. Some don't leave home due to fear of needing to use the bathroom, fear of not finding a bathroom, and of course, she said she asks a client to see their primary care provider as well. But great that you're asking about it and offering some appropriate strategies as well as referrals. I found it interesting. I teach a sort of a basic level biology of aging course, and I have a fairly simple assignment at the end to sort of bring things together, where the students interview an older adult and just ask them to tell them about 3 physical changes that they've noticed as they've aged, and then the student talks in the paper that they write up about the biological basis for those changes. And I'm always impressed and surprised at how many people in the course of these interviews, which are sometimes with an older family member or sometimes with someone they haven't met, but they bring up urinary tract issues,
Mhm.
even in that context,
Mhm.
as a physical change, but they're
Yep.
not maybe necessarily seeing any or mentioning it to other people.
Yep.
So, well, I think we have had an amazing talk today. This has been really, really helpful. Thank you, Dr. Yang. I've learned a lot, and it's very practical information, so we really appreciate that. Everyone, I will see you next week, and our talk next week is going to be on stroke treatment and prevention. So tune in then, and uh, there's a lot of people chatting in the chat box saying what an excellent presentation this is. So thanks, Dr. Yang.
All righty. You're welcome. It's been my pleasure and privilege to be here. Thanks for having me.
See everyone next week.